Welcome to the ANEW Insight Podcast, empowering and inspiring your journey to optimal health. Hosted by Dr. Supatra Tovar, clinical psychologist, registered dietitian, fitness expert, and author of Deprogram Diet Culture. Rethink your relationship with food, heal your mind, and live a diet-free life. I follow my guests' journey to optimal health, providing you with the keys to unlock your own wellness path. Tune in and evolve with us. Hello and welcome to the ANEW Insight Podcast. I am Dr. Supatra Tovar, and I'm so excited to have author, physician, and weight loss specialist, Dr. Adrienne Youdim, with us today. Dr. Adrienne, welcome.
Hi, Supatra. Nice to be with you.
Nice to have you here. I'm going to read a little bit about Dr. Adrienne, and then we're going to get into our questions. And I wanted to have this as a kind of a special episode that just really goes into and uncovers medical weight loss. This is something that I've really wanted to delve into. So I'm really excited to have such an amazing expert here to help us navigate through this. Dr. Adrienne Youdim is an esteemed physician, author, and thought leader specializing in medical weight loss, nutrition, and metabolic health. With a deep commitment to empowering individuals, she blends cutting-edge science with a compassionate approach to health. She is also the author of Hungry for More, Stories and Science to Inspire Weight Loss from the Inside Out, a book that delves into the emotional and psychological dimensions of weight loss. Beyond her clinical work, Dr. Youdim is a dedicated advocate for education and innovation in health and wellness, inspiring others to address the root causes of health challenges and achieve meaningful, lasting change. Dr. Adrienne, thank you so much for joining me.
It's a pleasure. Glad to be here.
So I really love to kind of explore people's inspiration to do what they do. What inspired you to go into medicine? And then what led you toward medical weight loss and metabolic health?
I don't remember deciding that I want to go into medicine. I just remember knowing that I wanted to go into medicine. It felt like one of those decisions that I was born with, and always felt very aligned in my work, but certainly had a pivot during my training where I went from feeling like medicine was an opportunity to fix people and wanting to do something as a proceduralist or a surgeon. Even I considered ICU medicine because it felt like it was the most impactful, to recognizing, and this is probably a realization that deepened as I started to practice medicine, that really people aren't there to fix, but to guide and to empower. And I think my work with obesity medicine, weight loss, is really profound in that way because, yes, we're dealing with a concrete issue, which is excess weight, which has comorbidity and chronic disease that's associated with it. But there is this whole emotional, spiritual, psychological dimension that, as I always say, our relationship with food is a window into our relationship with ourselves. And so if we can really lean into that hunger, so to speak, then people can acknowledge, where they are lacking, they can acknowledge their unmet needs, and then actually act upon that and find a way to live a more fulfilling, meaningful life.
I love that. And I love that you said that we're not here to fix, but maybe to empower and to guide. I'm wondering if this is also a personal journey for you. Did you experience difficulties with emotional versus physical hunger? And if so, how did you navigate through that?
Yes, absolutely. I mean, I will first say, and as I've written in the book, that emotional hunger is really hardwired in our neurobiology. And to say that we don't experience it, that it's not something that everyone experiences on some level, is kind of our own shame and bias speaking, as opposed to truth and reality. But as far as I'm concerned, and we're speaking on the eve of the announcement that Weight Watchers has gone bankrupt. So I think I went to my first Weight Watchers meeting when I was 11 or 12 years old. In my mind at the time, I was extremely obese, when now in retrospect, I know that I was just slightly overweight. And so I definitely grew up in a time of Slim Fast commercials and 17 magazine, and also being a child, a first generation American born to immigrants. I think it just fell into, and it being my, I don't know that it was really body dysmorphism, but my issues, my negative concept of my body, I think fell within this larger paradigm of just trying to fit in as a Middle Eastern child growing up in a very white Texas at the time, being an American, having parents who are very progressive and yet very much kind of ingrained in Persian Jewish culture. And so all of these ways in which I was different and unique, which now I pride myself on, were challenges that I think just made everything, exacerbated all the differences, right? My different size or shape or look or, eyebrows or what have you.
Absolutely. And I think a lot of people of color tend to really struggle in diet culture because it is just so white or Caucasian centric. Just to have this sort of body ideal is really based not in most people's cultures. And so they're always trying to sort of fit in to an ideal that isn't even appropriate or right for them. And when you experience this as a young child, I think it's creates deep, lasting impressions. How did you navigate yourself through that and away from dieting, away from Weight Watchers, and toward a healthier version of yourself?
There's a couple ways that I can answer that question, but what comes to mind first is to observe that I'm really an and person. So as medical director of the weight loss center at Cedars-Sinai, I practiced medical weight loss and I worked with the bariatric patients and helped my surgical colleagues get our patients ready for surgery. As a physician right now, I'm a firm believer of prescribing GLP-1 drugs, and I meditate and do mind body practices. And I bring this up because I think it's very important for us to acknowledge the societal pressures and the childhood imprints and all of those things that are very important. And there is a time for us to take responsibility to navigate our own health and well being. Whether that means finding the right tools, finding the right guides, finding the right professional help, whatever the case may be, I think having an and approach is really important. And I think I had an and epiphany. What I'll also say is that as I grew up and I think I navigated all of these other other ways in which I strove for perfection in terms of education, professional life, the white picket house sort of thing, all the ways in which we strive to achieve our goals and our dreams, but do it perfectly, reckoning with this idea of what my ideal body should be or is, and also just really being realistic about what I was seeing and not comparing to what was not ideal or not real. In short, I would say it's just awareness, awareness about what matters and the places in which we should all over ourselves, and when we take a step back, we think differently, and age helps too, right?
Oh,
Much right.
absolutely. I
Getting
I do
older.
think we become much less hard on ourselves, hopefully, the older that we get, and I do completely agree with you that I think the path to health and wellness starts with self-awareness. I think really, truly, non-judgmentally and with an open heart examining what's happening inside rather than dissociating, rather than running away from it or doing something mindless, becoming more mindful, I think is part of the key to really unlocking what your body is asking for and what it needs. And I think that you delve into that in a lot of ways in Hungry for More. You blend science with really deeply human storytelling Tell me your inspiration for writing it, and how did your patients' experiences help shape the themes in the book?
Well, I always say that when you work with people, you become the benefactor of many lives and many stories. And unless you're asleep at the job, you start to find patterns. You start to find universal threads that as a human I could personally relate to as well. And I kept seeing my patients come into the office, describing their experiences with shame and blame. And I'm not even talking about the weight, I'm talking about experiences in their lives like broken relationships or failed promotions or missteps in their personal or professional lives, the many happenings that happen in one's life. And there was always this sense of shame around it, not the open-minded, lack of judgment that you speak of, Supatra. And I almost felt like it was unfair because sitting behind the desk, I could say this story of Sally is the same as John, is the same as Karen, and is the same as mine, by the way. But they didn't have the benefit of seeing that universal thread that connects us all. So this book was really a love letter to my patients, a way of saying that we are all the same, that the stories and the struggle, the flavor of which may be different, are all universal. And it was really a way that I was trying to get people to acknowledge their own, to cultivate that self-compassion, right? Often the way to self-compassion is acknowledging our common humanity. And so that was really the attention behind the book.
Oh, I love that. I love what you just said. I think our common thread is our self compassion. And I agree with that wholeheartedly. So, in the book, you explore the idea that we're often hungry for things beyond food, purpose and connection and meaning and things like that. How do you help your patients begin to recognize and respond to these deeper forms of hunger?
Well, oftentimes in the conversation, I do a very extensive intake in terms of their history, their not just medical history, but personal history, whether there was any trauma. Not that I'm necessarily trained to deal with that, but at least if I can uncover it, then I can send them to the right people. And so in the course of the conversation, it comes up. I've been working in this deadbeat job for 30 years and I feel unvalidated, or I'm not living my purpose, or I'm in this relationship in which there are no boundaries and I'm not valued in my relationship. I'm not heard in my relationship. Or I'm playing small because I don't give myself credit or have enough confidence. Whatever the case may be, the story came out from the patient themselves, and they recognize that when they are under duress or distress, that they are more likely to soothe. And in fact, that's also validated in the science that difficult emotions raise hunger hormones, those very hormones that we are manipulating with Wegovy, Ozempic, the GLP-1 drugs. Those very hormones can shift in the direction of promoting more hunger when we are experiencing difficult emotions. And so what that means is that even if you're sated, even if you're physically fed with food, if you're experiencing a difficult emotion, that you can experience that hunger that is psychological, that is emotional, you can experience that hunger physically. And that drives people to consume, look, either food or drinking or smoking or getting on your phone and doom scrolling or gambling or overworking. Some of these coping skills are more socially accepted than others, but at the root, they are all the same.
Mm.
And the other thing I will say is that when we get that quick sense of satisfaction, again, from whatever it is that we are seeking, that good feeling is reinforced. And so we can't blame ourselves for going back for more because the coping mechanism is not curing the problem. It's not truly scratching the itch. and yet it is offering temporary calm or soothe.
Sure.
And because of that temporary nature, we are moved to go back again and again to seek that soothing.
Absolutely. I'm 100% with you on that. And I also think when we look and do a deeper dive into highly processed foods, they play into that drive and they actually try to manipulate that drive. And so that's, I think, where, and it hasn't necessarily been completely proven per se, but where a lot of clinicians believe food addiction actually comes from is a part of that, the kind of neural circuits that are activated when we have something pleasurable, like give a dopamine response. Food also helps us produce serotonin, so it makes us feel really good. But if we're not really truly conscious of the drive that will take us to eat, or we're really highly stressed, that's when I think the confusion happens. So, your work has consistently emphasized the emotional and psychological complexity behind eating behaviors, which I love. That's my area too. How do you think the medical community may have missed the mark or maybe even failed to address these dimensions?
I think we all play a role in we all play a role, right? And so like as a obesity medicine specialist, I'm not a policymaker, although I recognize that lots of social policies should and could be changed to support the health of my patients. So I think that our job as clinicians and as physicians and all aspects of healthcare is to recognize what we can offer, recognize where our limitations are, even if we decide to stay in our own lane, right? So I tend to be the and person, and so my curiosity allows me to toggle between prescribing a drug and meditating with my patient or talking about how their traumatic experiences may have shaped their health and their eating behavior. Somebody may not have that skill set nor want to, and that's okay. But I think our job is to know what we know, and more importantly, to know what we don't know, and when we should include other books. And what is kind of a personal pet peeve of mine, Supatra, and this goes on all sides, it's the surgeons who don't believe in medical weight loss. It's the internist who will never refer their patient to bariatric surgery. It's the dietitian or the social worker or therapist who badmouths doctors. That doesn't help anybody, right?
Mhm.
We have to recognize that we all play a role. And if our interest is really in the service of the health and well being of the people that we serve, that we need to be open-minded enough to know what's available, to know what we know, and know what we don't know, and to bring in the professionals who do.
I love that. I think that any health journey is a multidisciplinary approach. I think that you can go to your doctor, obviously, for the medical intervention. You may need a nutritionist who really has a much deeper understanding of nutrition and food's effects on the bodies and how that can work with a medical intervention. And I don't see that happening enough. I actually have been I'm on Facebook and I've been a part of some GLP-1 community groups. I just watch and observe and I offer my insight if it's appropriate at times. But I see so much confusion because of that. People are getting prescribed these medications and then there's just really like hardly any follow up, especially if they're getting it online. And so they're asking their peers on Facebook who might not even know. So I think really getting a full team to help people navigate through something like especially medicalized weight loss is so important. So let's
But
transition.
can I add
Yeah,
one thing, Suphatra? And that
sure.
is that the personal responsibility is also an important facet to this, right?
Mhm.
So there are plenty of people who are seeking these drugs from physicians who are not trained in anything obesity medicine or nutrition and weight loss. And I'm not dismissing the access issue here. That is a big issue. But they may not be candidates for the drug. And so they're going to another physician who doesn't know the difference between candidacy and not. Or they're so thrilled that they're losing weight. And I totally get that they completely disconnect from the fact that nutrition is still nutrition, right? Weight loss does not equate with nutrition. And actually, as I have a podcast called Health Bite, and this week I spoke with one of your colleagues, Gretchen Zimmerman, and we were talking about how to optimize nutrition on GLP-1s. And so it really takes, yes, there are physician issues, there are systemic issues, but we need to do better for ourselves. We need to take responsibility, seek out the knowledge where it's available, and do the hard work of recognizing that the drugs are doing its job of dampening the appetite, of turning down that food noise. But then the onuses are on us to capitalize on that, the fact that that patients are not bombarded with all these signals, to make the choices that they've always been intending to make or always knew that they should make.
Yes, and I think that it really speaks to the larger systemic issue of the influence of diet culture and why people, especially those who have been shamed for being overweight, are so desperate to lose weight that they may go to these compounding pharmacies or try to get it however they can get it. And it really, to me, just really speaks to how toxic diet culture can be in terms of its influence to make us want to change our weight and shape in order to fit in to this culture. So you
But when we
touched
talk about, I'm sorry to
No, that's
interrupt you.
okay.
This is where the conversation, the magic happens, right? But when we talk about diet culture, I feel like we're leaving out a huge group of people, a huge part of our population that has been dealing with excess weight, that actually qualifies for these medications, that has a significant amount of comorbidity like sleep apnea and obstructive sleep apnea, diabetes, or just poor quality of life, right? Like I have a patient who's in her late 60s. She works as a preschool teacher, and she didn't have a bunch of comorbidities on the chart, but until she lost weight with the help of these drugs, she couldn't get up and sit down with her toddlers during preschool. So I don't want to we need to be careful to again, this is the word of the day, to point out toxic diet culture, but also to recognize that that there are people who are experiencing health consequences of excess weight. And it's great that we finally have an option to help those people.
Yes, and absolutely. You're actually answering the question I was just about to
Oh,
ask,
good.
because I think it's so important that for someone who prescribes something like semaglutide, that they're determining, maybe even just beyond BMI, beyond these comorbidities, why it might be right for a patient. So if you could just briefly tell us how you determine whether or not these obesity medications are right for somebody, that would be so helpful.
Sure. So there are these criteria that professional societies put out that are very BMI centric. So they say that if you have a BMI of 30 or greater, and 30 is that BMI that is diagnostic of class 1 obesity, or right, that you're a candidate for this drug. Or if you are in the quote overweight category, and again, overweight is not just a description like the color yellow, it's based on this BMI of 27 or greater, or 25 or greater with comorbidities, although the for medication purposes, it's a cutoff of 27. These are the medical guidelines. Then you have the insurance guidelines. There are some insurance companies in California right now that will not approve these drugs unless you have a BMI of 40 or greater.
Wow.
That is associated with 100 pounds of excess weight. And actually, the majority of people who are on the individual plans right now, that is what is available to them, which is why I think so many people are going offline trying to find access to this drug. In terms of my personal approach, I very much follow the guidelines, but I also recognize that there are BMI cutoffs that are ethnic specific. So BMI of 30 is a Caucasian, typically, cutoff because it is at a BMI of 30 when they start to experience comorbidities. For Asian populations, that cutoff is much, much, much lower. In fact, they start to develop comorbidities at a BMI that would be considered normal by our medical standards. So, I mean, I look at the whole picture. I look at the patient, I look at the comorbidities, I look at how did they gain excess weight? How long have they been struggling with excess weight? What have they done in the past, right? If they've never done anything in the past, this was the same way we determined candidacy for bariatric surgery, right? If you've come to me, you gained weight over the last 6 months because of COVID, you've never done any behavioral strategy, you've never tried medications, obviously surgery is not the right step. But if you've been struggling with excess weight for 30 years and have or don't have comorbidities, right? And you've done all the dieting and exercise and you've tried the medications and you just can't get a handle of this, well, then maybe it's time to look at higher level interventions. So it really is this kind of holistic approach. And then in terms of like the amount of weight loss, that's also something that has to be kept in mind, because I have patients who come in and God, I can't tell you how many times I hear this. Nothing works. I just want to lose 10 pounds. I just want to lose 20 pounds, right? And then they lose the 20 pounds and now it's like, I want to lose 30 pounds. And they lose the 30 pounds and now I want. And sometimes, look, if you are 100 pounds of excess weight, then losing 50 pounds may be important to get your comorbidities under check, to get your joint pain under check, right? But I also have patients that I get into these uncomfortable conversations because they've lost a lot of weight. They are now at the lower level of the BMI. I don't go based on looks, but just looking at them doesn't, even as it doesn't look healthy, it doesn't look right. And I have to struggle with them in terms of like, we need to dial back the dose, or we shouldn't dial up the dose.
Yes.
And so these considerations go both ways in terms of starting the medication. And we don't talk about stopping it, but where do we draw the line? Because some people will continue to lose weight. And usually they're not the people who really, I don't want to say need to, but it's not the guy or gal who's 100 pounds overweight. It's usually the person who probably shouldn't have been on it to begin with, or it was a really soft call. And now it's excessive.
Yes. And we're starting to see a lot more problematic eating disorders, disordered eating coming from, I think, the misuse of the medication. And so I want to get into that. We're out of time for this. I can't even believe we're out of time for this half.
Wow.
This is such a fascinating topic. And I'm really, really impressed with you and your diligence and discernment of who should be maybe on this medication and who might it not be right for. I think that we need a lot more doctors out there like you who are really kind of looking holistically at the whole picture and really examining a person's history to determine if this is the right path for them. So we're going to get into that in the second half. Dr. Adrienne, I'm so excited to talk to you some more about this. Everybody, stay tuned for the next half of this amazing episode with author, physician, and weight loss specialist, Dr. Adrienne Youdim. Thanks so much. Thanks for tuning into the ANEW Insight Podcast. Please remember, the contents shared on this podcast is for entertainment purposes only and does not constitute medical advice. You can find us anywhere podcasts are streaming, on YouTube at my.anew.insight and at anew-insight.com under the ANEW Insight Podcast tab. And follow us on our socials at my.anew.insight on Facebook, Instagram, TikTok, and Threads for more updates. Tune in next time and evolve with us.